Well, it's a pleasure to be here today, and it's nice to meet everyone. My name is Kathleen Gamblin, and I am the System Manager for Navigation at Piedmont Healthcare. And so we have 22 hospitals across Georgia, and so I oversee navigation for those hospitals. But you never really stop navigating. So we are currently standing up a sarcoma program, and so at the moment I am serving as the navigator for sarcoma to get them going until I get my position hired. And then exciting for me is we are revamping our lung program, and we have not had a lung navigator. We have a lung screening navigator. We have not had a lung navigator when I came in, and so that is what I'm working on now. And selfishly, it may take me a little bit to hire someone because these are the patients that I love, so it may take me a little bit longer to give up navigation for these patients. I started in navigation back in 2006, and at that point there were about 5 articles written in the literature about navigation, not much going on. And I started out in a multidisciplinary lung cancer clinic where we would bring patients in with suspicious findings, and our goal really was to expedite them from time of suspicious finding to the time we got them into treatment. And so when we did the initial study, it was about 53 days. So 53 days from the point we had a suspicious finding until we were able to start treatment. And when I left that program, we had got that down to 13 days. So 13 days from suspicious finding to starting treatment, which was absolutely incredible. And it involves, a lot of coordination of care and getting patients in quickly and not letting things rest. If we got a non-diagnostic back on a biopsy, kind of talking to the doctors right then and saying, what are we going to do next? Not waiting for the patient's next doctor's appointment, not waiting for the next tumor board, but really kind of pushing them so that we could keep moving forward with patients. And so I did that for about 5 or 6 years, and then I was asked to start one of the National Cancer Institutes, had a community cancer center program where they brought hospitals on, and there was a hospital here in Atlanta that was brought on, and navigation was part of that program. And so they asked me to come and start navigation there, and I started out as the lung navigator there until we got going and we were able to hire somebody. And so lung has just been a passion of mine all along, so I'm incredibly just grateful. I've been involved with the ONS, so I authored and co-edited on the first book on Oncology Nurse Navigation and what that role looked like. So what is navigation? What you will hear from us in the field is if you've seen one navigation program, you've seen one navigation program. Navigation is really designed to meet the needs of the patients and the community and the hospital that it serves. And so it looks a little bit differently in a lot of places. I will say that for me, when I define navigation, I look at it as a proactive, intentional process of collaborating with patients and their families to provide guidance as they negotiate the maze and barriers in treatment. Because when you're diagnosed, you're standing in front of this giant maze and you're not sure where to go and what to do next. And so our job in navigation is kind of to take your hand and help you navigate that maze. We don't always have all the answers, but we can point you to who does. So I try to always remember that, it's not always my job to have the full and complete answer, but it is my job to know where I can seek out those answers for patients and give them to patients and their families. So for us, what navigation looks like is when we either have a suspicious finding, and there are some programs that really require a diagnosis. I have found in lung that I would much rather connect with a patient in that time of uncertainty. And if it turns out not to be cancer, then great. We can, that is fabulous. I will celebrate with you and I will send you on your way. But if you do end up having cancer, I've been able to make that connection early, hopefully answered some of your questions about next steps. And then we begin to walk you through the process. And some of that is making sure that you understand your diagnosis, understanding your pathology report, helping you formulate the questions you may want to ask your doctor, because that's very important. And then a big part of what I do is also empowering patients to take control of their care in the ways that they can. You are your own best advocate, you and your family. No one is going to care about your life like you do. And so empowering patients that, yes, you absolutely can ask the hard questions of your doctor. You can absolutely should feel comfortable with the healthcare providers that you're involved with. And just really empowering patients, giving them resources, pointing them out in places to go. For me, that looks like if a patient wants a second opinion, helping you to get that second opinion, helping you to decide, where you're going to either send your records or whether you're going to go visit. How can I expedite that process for you and make it easier on you? Which kind of leads me to the point of, if you want a second opinion, absolutely you're right, and absolutely something that no physician should ever complain about. It's why in navigation and in our program, we stay away from referrals. We don't refer patients to any physicians, because to me, that's a conflict of interest. I work for the patient. My job is to be an advocate for the patient. It is not to be, a source of referrals for our physician groups. It's not to make their lives easier. I think a lot of what I do does help them and make their lives easier, but my job is to make the patient's life easier. We do a lot of that with training with our new navigators to make sure that they understand that. We're your handmaiden. We are not the physician's handmaiden. And so, once we get through that and we start getting patients into treatment, then we're that constant check-in for the patient. How are you doing? We work very closely with medical oncology and radiation oncology. We encourage our patients to connect with them for any clinical issues, any side effects you're having. Sometimes a patient isn't quite sure if they should call, and they can always call me and say, hey, I'm having this. I don't know if I should call, and we're always encouraging and connecting patients. We do a barrier to care assessment. It's a 7-part assessment, and we really try to assess the patient as a whole person, looking at all these areas of your life to see where there may be a barrier that could keep you from getting the care that you need. So there's the standards of like transportation, maybe that, you don't have a ride to the doctor's office, or it could be insurance. It could be, finances, affording the co-pays. But then there's other, does a patient have any social support? Do you have support in the community? Is there someone that lives with you? So we do an assessment on that, because every person needs support in their journey, and we want to know that and be able to provide that to patients. We also look at, home situations. We had a patient that we got into treatment, called them to talk to them. How are you doing? I'm doing great. The treatment's going great. If I could just get rid of these roaches in my home. And that's a little bit outside of my purview a lot of the time. But we were able to get a company to come in and to do an extermination and then to follow up and work with that patient. And so, a lot of times I think healthcare professionals, we think we know what you need. And we can be a little bit paternalistic about this. You need to do this. You should do this. But the reality is, I have trained our navigators to always ask, what is it that I can do for you today? Because I can almost guess that about 75% of the time, what I think your need is not what you're really thinking about. I get patients who are supposed to go in the hospital and they've got a cat at home. Or I had a lady who had sole custody of her 2 great-grandsons and was supposed to have surgery. And the doctor was getting ready to schedule her to come in and have her surgery, and no one thought about these 2 great-grandsons. Who was going to take care of them during that time period? What kind of support did she need? And so we try to always work with, what is it that the patient needs? What is it that you need me to work on today? What is it that I can help you with? In oncology, we feel very strongly about people getting treatment. For some people, that's not the right choice for them, and they choose not to do that. And so really kind of impressing upon people their right to determine the treatment that they're going to have and what they want to do, and asking them, like, what is it that you want? I had a lady that was diagnosed at age 50, and she had widespread metastatic disease, and she was here in Georgia, not originally from Georgia. She was a single mom with a 10-year-old. And I said, what is it that you want? Because they were like, you need to start treatment yesterday. You absolutely have to start treatment. And I went to see her and I said, what is it that you want? And she said, I want to go home to California to be with my family. And I said, okay. And so I went to talk to the physician, and he said, well, she's never going to get back there because no one's going to fly her. And I said, okay, well, if I can find someone to fly her, will you sign off on her going? And he said, I will, but you won't find anyone. So challenge accepted. We did find an airline to fly her. We did find a private donor that paid for it. And she was able to go home and take her daughter and go home to her family. And that was what was most important to her. I think my message is always, one, the first thing I tell patients is you're not a number and you're not a statistic. You are you. And there's a lot of unique things to you. So, getting on the internet and reading statistics can make you very sad very quickly. But I encourage people to understand that they are unique and they're not a statistic. Two, making sure that patients understand their diagnosis and that they understand what that means, and then figuring out what the barriers to care are that they may have and helping them address those barriers to care. And then just continuing to be a support throughout the process. I have patients that I'll call once and then they'll tell me, I'm good, I'll call you if I need anything. And I always find it interesting because honestly, most of my lung patients over the years have been very self-sufficient. And I adore them. I will get these, 65, 70-year-old men who are like, I don't need anything, I'm fine, with stage 4 disease. And I work with navigators that take care of breast, and God bless them, because, they may get a stage 1 breast cancer patient who is just, very emotionally distraught and has all these things going on. And so I love my lung patients. Sometimes I have to push them a little bit. No, what is it that you need? Because they will generally tell me, I'm fine, I don't need much, I'm good, and we have to do some pushing. But making sure that we're addressing the barriers to care, and then just making sure that we're empowering the patient along the journey to take advantage of the things that are out there, to accept the help that they need, because most of us are a little bit loath to accept help from those around us. And so that is something that I think we work on with all of our patients, is accepting the help that's been offered to you, or how do you take advantage of that help that's been offered to you. So one of the things that we talk about a lot is deciding what things that you may be comfortable with letting someone help you with, and what are things that you like to do yourself. I know one thing that people frequently talk about when someone gets sick is, oh, we're going to do meals for them. Well, I had one patient where cooking was kind of their language of love for the family, and what they wanted to do was they wanted to maintain that love language. And so meals wasn't a great option for them. And so I kind of helped them navigate, okay, what are some other things? Because the people around you want to help, and they will say to you, oh, call me if you need anything, because they don't know what to do for you, and you don't necessarily know how to ask them or want to ask them. And so you have someone wanting to give help, someone who could use some help, but the help is never given because you've never come together. And so I ask patients, think about the things that maybe you would be okay with someone else doing, whether that's picking up some groceries, whether that's picking up prescriptions. Could they provide a ride for you to, an appointment that would free, maybe a caregiver up? Thinking about those things ahead of time so that when people ask, that you have that person. Another thing we talk about is, second to being the patient, caregiving is exhausting. You're taking care of this person you love, there's a lot going on. And yet I feel that the caregivers also asked to serve in this function of being a clearinghouse for information, and that's a lot. So they have the phone calls coming in from other family, from friends, how are they doing? And so if they're able, a lot of times I talk to the family about having a third person, someone who's willing to serve as that information person so that you can direct people to them. You know, if you want to call and check on mom, you can call Sally. We're going to keep Sally updated. And that just helps relieve some of the burden from the caregiver, from the patient of, you know, updating people, because people care about you and they want to know. But returning phone calls when you're not feeling well, or when you're in the midst of taking care of someone who's not feeling well, can be very, very overwhelming, and get overwhelming very quickly. And so the job of navigation really should be to support the patient throughout the process. So the question often gets asked, what if I don't have a navigator? I think with any care that you're getting, the question to ask is, what kind of oncology support do you offer to patients? Navigators go by different names. We're not always called navigators. Some people are care coordinators. There may be social workers in place. So you may not get a nurse specifically, but there should be someone that can help you guide your journey. And sometimes that turns out to be a nurse within your physician's office that takes on that role of supporting patients and tracking them. So I would always say, you know, kind of ask what kind of support services are offered or available to me. And then there are a lot of, you know, organizations out there that do provide nurses that can answer questions in your area, that can offer resources in your area. So sometimes it is tapping in to those people as well. And I think for myself, I'm always available. You know, I navigate in my private life. So, you know, people that know me, you know, from church or around town, I will get a call and they will say, hey, my brother's sister, cousin was diagnosed. Can you, you know, kind of help me? And I will tell you that most navigators are very willing to do that. I'm always willing to do that, you know, to be a listening ear and to kind of help direct somebody if they need that. Lynn has my contact information. I am happy at any point to help if you need something or you know, kind of are not sure where to go next. I don't do recommendations for treatment, but what I will do is help you kind of sort out, you know, what has been recommended to you, and then working through those decisions. And that's what a good navigator should do. You know, we are going to reinforce what your physicians have told you that we work with, but at the same time, we're going to honor your wishes and kind of walk through those decisions with you so that you can make the decisions that that are best for you. And I'm going to stop because I keep talking about it forever, but do you guys have any questions?
Where were you when I was diagnosed? Oh my gosh. When I real quickly, I did a lung cancer, CT lung cancer screening, and there was a suspicious tumor. So my doctor sent me for the PET scan, and he got a hold of me after a few days and said, you have cancer. And it's like, what? And so I went into the office and he handed me a piece of paper, or excuse me, he said the nurse will be in with a few referrals, and they handed me a little Post-it note with a few doctor names on it and handed it to me. And my doctor said a few weeks isn't going to make a big difference. Well, I have small cell lung cancer, so it could have made a huge difference. I was diagnosed limited, of course, but anyway, thank gosh I got into a great pulmonary and a cancer care center and went to treatment like within probably 3, maybe even 2.5 weeks. I went right to treatment. So
good.
I sure could have used you through that. I was like, are you kidding me? Went home and tried to get some appointments, and I had an appointment a month out. And thank God my pulmonary doctor saw my PET scan, and the nurse called me and said, the doctor wants to see you Monday morning. And that was a Friday. So thank God it got someone's attention.
No, but you're right. And that's, I think, what, navigation really started out of working with patients with disparities. So people who didn't have access to resources, who didn't have insurance and things. But the reality is that every patient can use navigation, because unless you're a multimillionaire or even a millionaire, chances are if you call for an appointment, someone is not going to immediately say, oh, sure, come on in and we'll see you today. So it's helpful to have those people to call and say, no, that's not going to work. We need to get this patient in sooner.
I have another comment. First of all, Jan, you know how much I love that you're part of our group. This woman started out at a very bad place, and she's in such a good spot right now, aren't you, Jan? It's fantastic.
Thank you. Thanks to your support.
Oh, you've always got it, Del. I didn't even know my cancer center had a nurse navigator until 5 years after I was diagnosed. When I finally reached out to her, which was just several months ago, what I wanted to talk to her about was, number one, livelung.org, and how can I get the word out to the newest patients? And number two, and Lynn had been gracious and sent me a bunch of the Hope Totes that I brought in. And I asked her if she'd pass those out to anyone, and I never got an answer. I'm trying to figure out how to get, now that I know there's a nurse navigator, I've never met her in person, how to get someone like she in touch.
One thing that I usually will ask, so I think first, educating our new patients to always ask, is there a nurse navigator, or is there a navigator? Is there a patient navigator? That's the first thing that we want to encourage our newly diagnosed patients to ask, to see what is available to them. And then second, if there is a nurse navigator, to kind of ask them what their role is, because I will tell you, this role spans quite a bit of space. I have seen navigators that are used for, quite honestly, market share. It looks good to have a navigator, and so, we have a navigator and they do, events in the community and things like that. So it's nice to know exactly how those navigators work, and what you can expect from them, because there should be a process by which they navigate patients. I will tell you that there's been a bit of a back and forth. So the Commission on Cancer that accredits quite a few of the cancer centers, they for a while had a standard that if you were going to be accredited by them, you had to have a navigation process. And didn't say you had to have navigators, but you had to be able to demonstrate the process by which your patients could be navigated through your system. And so systems went out and people hired navigators, here and there. In addition, in January of this year, Medicare came through and they did approve billing for navigation. Now, I have my own personal feelings about that. I worry a little bit when we start billing for services, because I don't ever want anyone to be left out. And I feel like, sometimes healthcare becomes a business. And so we start looking for that, the dollar, and saying, okay, well, how can we, get revenue on this? Because nurses are a big cost to all hospitals. And for most services, there's no billing for nurses' services. But I think with this new ability to bill, we're going to see more centers add navigators. That is a little bit tricky, because a lot of times centers hire navigators. They don't really know what navigators do, and they kind of say, go forth and prosper. And so unless you have a system of navigation in place, like we do here, where we kind of start training them and say, okay, these are our expectations for navigation, navigators can get caught up in all kinds of extra duties. And, the more things that you have to do, the less ability you have, I think, to touch patients. And I always laugh, because for people who frequently have to justify, well, what is it that you do? Navigation seems to come up in every conversation when there's a task to be done and nobody's sure who should do it. I hear, well, can't the navigators do that? And I'm like, no, we're a little covered up as it is. So I think just asking, what it is they do. I would also encourage, if you really don't get any satisfaction around that, especially Maida, I would connect with the Oncology Support Services Manager or whoever's over that department and say to them, hey, I have access, I have LiveLung, this great organization that's willing to provide these bags for patients. how can we make this happen? How can we make sure that patients know? Because I think we not only advocate for ourselves, but we advocate for our fellow patients. And so making people, kind of bringing that up, like how do resources, because one of the things that I have found that we're trying to work better on is resources are only as good as the people that know about them. And I feel like sometimes navigators get in the rut of we refer to these couple of places, or, I'm comfortable referring here, and so that's what I do. And so one of the projects we're working on right now is to say, making sure that every one of our patients in a disease site gets referred to a disease-specific organization, or multiple, if there are multiple in that area. So making sure that all my lung patients get referred to LiveLung, get referred to longevity, so that they have that community of people around them. And then, working through our resources to make sure that we know what is out there. I am fortunate that our hospital just put in within our Epic EMR system, we actually have a huge referral-based system. So we can plug in, what the need of the patient is, what the area that they live in, and it will pull up, resources for us, which is great. Because now we've started, as I find resources, I check them, make sure that they're in our database so that our navigators can find them easily. And then that helps us track who we're referring to.
I'd venture to say the majority of us, especially in the small cell group, I have extensive small cell, have found LiveLung by accident. No one referred most of us to LiveLung. In my case, I happened to go online on Facebook to look for a community. And it was through that community that I encountered Lynn and LiveLung. And as I've said many times, LiveLung emotionally saved my life. So, that is really important. And that's what I was taking notes on to contact my oncology department.
And just letting your physicians know, the nurses in your office, the people that you're working with, how great this group has been for you. And encouraging them to refer, encouraging them, hey, if we have flyers, how do I get them somewhere in your office? How can we, because this, as you said, emotionally saved me, and we want that for other patients as well.
I was fortunate enough to find the right providers on my own on my journey, which has been since 2018. But I'm wondering, I'm not even sure that my hospital has a Nurse Navigator program. I'm wondering whether or not folks that are on the journey and have been doing okay could benefit in some way by if I found organizations such as LiveLung and Longevity and others, also on my own or through friends. But I'm wondering if there is a Nurse Navigator program that I find that's available, whether or not I could benefit in any way. Of course, none of us knows where, what's going to be the next day. So that's why I bring that up.
If you have a Nurse Navigator program, and even if you're into your journey, I think it's always beneficial if you at least connect with them, talk to them, kind of find out what it is that they do, what they're available to help with, because I will tell you, navigators in general are much easier to get a hold of than an office person. So when a patient calls me, I generally can pick up the phone right away, or if I don't pick up the phone right away, I'm able to call back within 15, 20 minutes to a patient. And so it's kind of nice to have that. I always tell them, keep me in your back pocket. And even patients will tell me, I don't need anything, I'm fine. I'm like, look, I just tuck my number away, stick it on the side of your fridge, because there may come a point where you're like, you know what, I don't know who else to ask. And, oh, wait, there's that navigator, and she said or he said to call me if they needed something. And so I think there's always benefit to meeting them. And I think there's also benefit to sharing your experience, good and bad, with them, because navigators, one of the things that navigators are supposed to do, as per our standards and our competencies, is that we're also supposed to be healthcare change agents. So when something isn't working for our patients, I want to be able to bring that forward and say, hey, we're struggling in this area. It's a different disease site, but as I've been working with sarcoma patients, I realized very quickly we were struggling with pathology, and pathology literally was not coming back for a month sometimes because it needed to go out for additional testing and then that process. And so it was bringing it up and saying, hey, like, this isn't satisfactory. We need to fix this. And a little over kind of 6 months since I started that conversation, we've partnered with a new NCI center that does our second reads on those pathologies. And, we're down to under 2 weeks, which is remarkable because these, pathologies need a second read on them. And so, sharing your experiences, and I know some people see that as complaining. I don't. Like, this is your life. If something isn't working well, someone needs to know about that, so that you can continue, they can continue to work to improve, because we're here for the patient. And I think sometimes that gets lost in the mix of business, and that isn't okay.
Could there be useful or suitable if things go awry? Because cancer is an evil entity that wants to get us. That's its job in life. If that happens, is a nurse navigation program helpful in terms of talking to you about palliative care, or if the worst comes, hospice?
Yes.
And it's in my 6th year now, so for me,
That is awesome.
Yeah, I'm still hanging in, which is great, and I think a number of people that I know from this group have been as well, which is wonderful. But it's like walking out in the middle of the street and crossing the street. You never know what's going to happen, and you sure don't know what's going to happen in this thing. So is nurse navigation helpful for that?
Yes, they can have that discussion with you, and again, finding out what your preferences are, what your needs are, helping you to communicate. Sometimes there's a gap in that communication with your physician for whatever reason, and they can kind of help it. I've had patients who've had the conversation with me that say, I'm ready to stop treatment. And I can kind of clue the doctor in ahead of time. Hey, I know they've got an appointment with you tomorrow. This is kind of where they are, and what they're thinking. And it kind of helps prepare the physician for the conversation too, if there's going to be any questions that they have. So I think absolutely the nurse navigator can be very helpful in that.
Well, Kathleen, let me also ask you if I am considering clinical trials, I'm like, I want to hear more about this. Is that something I would also speak to you about, to speak to my nurse navigator about? And because let's face it, clinicaltrials.gov is just so overwhelming. Anyone who's gone there, it's like, what? How do I do? And, and I'm pretty tech savvy. So would you be able to help us with that, or at least give us some ideas?
Yeah, so what I will tell you is there are some nurse navigators that are more comfortable than others. I've been working with our nurse navigators to really get us to the point of comfort of doing that initial discussion with patients about clinical trials and kind of, what a clinical trial is, why it can be important to them, all of those things. And then that nurse navigator will have connection to either a clinical trials person within their institution that they can send you to, or they can also help with those, like clinicaltrials.gov. We can direct you to those sites and help you a little bit. And then also depending on, sometimes there's additional people we know that you can talk to. And then what we try to do here is we try to highlight 1 or 2 trials a month that we learn about. And then we kind of look for patients that may meet some of that criteria. And it's not my job to push it to the patient, but I will let our clinical trials department know, hey, there is this patient. They may benefit from this. Because as you may or may not know with clinical trials, sometimes clinical trials, they need to happen. If you're going to be enrolled in a trial, that trial may require that you do that before you do something else. And so if you go ahead and start that something else, then you'll no longer qualify for that trial. And so we try to get patients and refer patients that may meet criteria so that at least the conversation can be had, and then the patient has the right to make that decision, one way or another, about whether they want to participate in the trial or not.
I love how you said that if you've known one nurse navigator, you've known one nurse navigator. Nurse navigators are not created equal. I know that my sister-in-law was diagnosed with breast cancer at the end of last year. And of course, my love for nurse navigators and how much we love you all, and we know how important you are. I said, you need to make sure you have a nurse navigator. And she said, I have one. And I said, well, she should have talked to you about, she should have given you the roadmap and talked to you. And like, no, she scheduled me for radiation. She scheduled me for this. She scheduled me for that. So basically her nurse navigator was essentially a scheduler. And so she left that meeting with that nurse navigator, and I use that in quotes, as with nothing more than appointments, no knowledge about what kind of breast cancer she had or anything like that. So what do you do? And I know that she's not alone. She's in Detroit. So she has big hospitals, and even at U of M, she still is having this issue. What do we do when we know we need you? Because really, let's face it, what you've just described, what you do, you're the patient's advocate. I mean, you are like, their pit bull. So so how do I get a pit bull if I don't have one at my access?
So I think, two things, as I said, looking for, kind of asking the question, who is here that can answer all of my questions, walk me through the roadmap? Who is that support person? And because sometimes you use that word nurse navigator and you're very right, you're going to get someone in scheduling. I will tell you, in that rare and complex cancers, navigation can kind of be a mixed model. So as I work in sarcoma, it is a rare cancer. And so I do work with scheduling. I do schedule appointments for patients if I need to fit them in very quickly, or there's a reason, we're not just doing a standard. So I will get involved in that piece. I actually will. We get a lot of patients from outlying areas in Georgia. And so I think, where Sarah is, we had a patient from LaGrange that came up to see our ortho-oncologist. He was finished treatment. He needed to start treatment. And so I was able to call down there. I actually called Sarah's center and sent him there for treatment. So there are some navigators that kind of do a mix of that. But I think if you're coming upon someone who's saying, I'm a navigator, this is what I do, I schedule, I think the conversation can be had about, who do you have that can talk to me, that can, connect me to resources that can answer my questions. And sometimes in the bigger centers, especially like the university or the academic centers, you may find that it's a nurse practitioner that really functions on that clinical level that will answer a lot of the questions for me. And then I think, on the other hand, when you're not in that active phase of kind of struggling to find that person, it is a good conversation to have with your providers. My experience has been, I really was looking for somebody that had more time to sit down with me and talk to me about this or provide me with this. And my understanding, of navigation was this is something they were going to be able to do for me, and it didn't happen. Like, can we talk about, how you can expand your resources to have these people? Because I think navigation is one of those fields where anecdotally, I can tell you beyond a shadow of a doubt that it works, that my patients, are happy, that they're well taken care of. Metric-wise, it's very hard for us to do that proof that everybody seems to want, because there's a lot of people that input into your care. And so to say a lot of times, this was all the navigator that did this, makes it difficult for us to, have metrics and pull numbers that support the value of navigation. But I think it's the anecdotal stories of the patients that are going to prove far more than anything else the value of navigation for patients. And there are limited studies. I shouldn't say there's nothing. There are limited studies out there that do show the value of navigation. It's just not been able to be done on this widespread level like we would like.
I agree wholeheartedly. And I just wanted to add, I mean, because I'm a almost 19-year survivor now, and maybe some of the others here who are long-term survivors, they might remember, I mean, to have a thoracic nurse navigator is a gift and a treasure. Even if it's not a great one, I mean, bad pizza, it's still okay, right? But there were no nurse navigators for lung when I was diagnosed, but curiously, there were nurse navigators back then for breast. And so, I would see that. And I think you would probably agree, Kathleen, but in the beginning, it's just like, I mean, they talk about being a navigator. I mean, you're on a journey, right? And in the beginning, it's kind of a maze, and you don't even know where the freaking radiation location is. I mean, you have to get your bearings, and the nurse navigator is so crucially important, especially in the beginning, and or when you're going to a new provider, or you're starting a new treatment. And I think that's just like if you're going down Interstate 95. Well, you're just sailing along and you're doing okay. You might be tired or whatever, but you're on the right path, and you're on the right path. But when you Lynn can attest to this. We were using our GPS, and I was using Waze. We were on our way back from the back roads in Georgia, and there was a road closed, and Waze couldn't figure it out, that the road was closed. We couldn't get in there. And I'm like, totally lost. That's when I needed a nurse navigator. You know what I'm saying? Just when you get stumped on your lung cancer journey, your treatment journey, whether it's side effects or like Steve talked about, maybe you need some advice about entering hospice, or frankly, also if you don't mind just talking a little bit more about palliative care, because there's a lot of misconceptions about palliative care, and people think that doesn't come until the very end, when in fact it should be from day one. But anyway, sorry to run my mouth, but you need that navigation more urgently at certain times in your journey than at other times, right?
I agree. And I think that the other thing that I love is we had a day at the Capitol not long ago where we did a picture with the governor and for lung cancer awareness, and I got a chance to talk to Chris Draft, and we talked about breast cancer and everything being pink and all of that. But one of the things he said that struck me that I thought was so true is, for quite a few years now, we've spent a lot of time in lung cancer focused on screening and screening and screening. And the reality is, at least from what I see with our patients, is a lot of the patients that are diagnosed, they're not people that would have maybe even met the criteria for screening. They're not smokers, they're under the age group, they're past the number of years since they quit, whatever. So there's a lot of people that don't even fall into that group. And so Chris was talking to me about we need to change the message of lung cancer, and the message is no longer just get screened. For a long time in lung cancer, we focused on just get screened. The focus now needs to be on survivorship and what does everybody need along this journey. And that's where I feel like we're headed now is the survivorship piece. And that's where I hope to see a switch in thoracic navigation, especially because for a long time, I didn't have patients that survived very long, but now people they're not just living, they're thriving, and, they are living their life. And so the new message is, how do we help people survive? So I think palliative care is one of those. There has been a traditional kind of tug of war sometimes between medical oncology and palliative care, because medical oncology likes to manage their patients. And then you've added this other physician in. But the value that a palliative care physician brings from the beginning and their team it's just invaluable, because they also take into account, what are the things that you want to accomplish in your life? What do you want to be able to do? What do you need to be more comfortable to do? And so bringing them in early on and getting that referral to them early on can be life-changing for you, because they can help with that management, with medications that make you more comfortable. And so I always recommend, palliative care. I think that is a critical component. I think the second thing that is really misunderstood is hospice. I'm a huge advocate for hospice based on a diagnosis code alone. If you meet, I have patients, if you meet criteria, let's take advantage of the services that they have to offer. We've changed a lot from the days where we said you can't get any treatment at all. Like if you're, if you're in hospice, there's nothing going on. There have been some changes in that realm. So if that ability is there, I encourage my patients to take advantage of a team that's focused on them, because I think that is truly one of the areas where we see that multidisciplinary care we talk about so often. And I think one of the things that's frustrating as a nurse is when we talk about multidisciplinary care, the physicians most of the time are talking about other physicians and other specialties. I feel like multidisciplinary care is truly the dietary person, the social worker, the genetic counselor, in addition to those physicians, because you want this complete package of people who are looking out for you and looking at what's best for you that you can rely on. And so hospice is one of the areas that does do that. So I also encourage patients, if they meet criteria for that and they want to take advantage of that, I think one of our saddest things is most of the time hospice is utilized, in under that last 2 weeks of life. And you don't get the full benefit of having created a relationship with these people. And the reality is, too, I've seen patients come off hospice. I've had lung patients who, according to diagnosis, they met criteria, but guess what? A clinical trial opened up, a new treatment opened up, and they're surviving and thriving today. And they signed off of hospice, and, they're all the better for it. And so I think taking advantage of those services, and again, nobody knows you like you and your family and your loved ones around you. So you can't ever be uncomfortable to push for the things that you need. Like, if you need something, and believe me when I tell you, there are difficult patients, and they are not people that push for services that are needed or referrals that are needed. Like my truly difficult patients, they're not difficult because they are adamant about the care that they are getting, they're difficult for far different reasons. And so I think sometimes we're worried that we'll get, labeled to be a difficult patient. You know what? I only hope that if I am ever in any of your shoes, that I am a difficult patient, and that I advocate for myself or for my loved ones.
I want to jump in here real quick because I've been living with stage 4 lung cancer for going on 20 years now. And there's a lot of reasons. I was fortunate enough to land in the hands of top-notch oncologists that specialize. And I run a support group online, and I started one here in our local area. And the main thing I think is that people need to seek out specialists. That's number one importance, because our local oncologists, God bless them, they deal with, a plethora of cancers. But I'm on my 6th clinical trial, so I've gone that route, and I'm on palliative care, and I'm doing just fine right now. There are a lot of misconceptions about clinical trials. People think that you get a placebo, the placebo, and you don't get anything. And so anytime I get a chance, and everyone should probably do this, explain to whoever. I've not eavesdropped, but I hear people talking in the waiting room, and I'll say, oh no, that's, you get the standard of care at least.
Yeah, and I think, and people would much rather hear from you than they would even hear from me. Do you know what I'm saying? Somebody else that has been in their shoes, that experience is far more credible, than me just telling you as a healthcare professional. You saying, hey, that isn't true. You do get the standard of care.
Right.
That's more credible than I could ever be in a situation with a patient. So I think doing that. And going back to the specialist, I do, one thing I talk to patients about is, what I have found at least is, I'm in a city with Emory. Emory is an NCI center. But what I have found, even with Emory, is if a patient goes to Emory for a second opinion, and Emory does not have a clinical trial open for them, does not have a different treatment that they feel, Emory will send that patient back to their original oncologist. I've seen MD Anderson do the same thing. They're not trying to necessarily keep all of these patients, because what we know is that 80 to 90% of oncology care occurs in the community. It does not occur at these academic centers. So taking advantage of the knowledge that is at those centers, you can take advantage of that knowledge, but also be treated close to home. So, just keep that in mind. They're really not trying to get people to fly to Texas, every 3 weeks for a treatment that you can get in your local community. They're going to recommend that you stay in your local community.
Right. Once a treatment plan was established for me, at first I had to go up every 3 months to New York, and I live in Florida. But the sponsor of the trial paid for the transport. This is another thing I'm yapping about all the time. The sponsor of the trial covered the cost of transportation and lodging, and I had a card that they gave me to use for cab fare and food. So that worked, and I've been on the trial for 6 years now. Yeah, and we're kind of phasing that I don't even need to go to New York. We just do telehealth, and I get my care here locally. So you can start off, initially with all the needs to be done at the beginning of a trial at the big cancer center or wherever, and then transfer your care to your local oncologist.
Kathleen, thank you so, so much. We appreciate you being here. And my gosh, seriously, Dusty and I are still pinching ourselves. We can't believe you're part of our team in Georgia. So thank you.
Well, I'm so excited to join you. I can't believe it either on my end, because I am so excited to kind of dive back into, the disease site and the people that I love the most. And so I am beyond excited. And I'm excited for the state of Georgia. This is something that we really need here. To expand and to be able to give to our patients. And I want to be able to, my goal is that one day lung patients get the same, all the same kind of care that I see in breast, the same kind of support, that raising of funds, that understanding that, that we will get rid of the day where the first question anybody asks you is, did you smoke? I want to, we are going to get there, and we are going to, we are moving from just, we want to prevent this to there is survivorship, and people are going to survive and live and thrive. So thank you all so much for having me.